Next, we have Dr. Shilpa Tarini. She is our young dynamic cornea faculty in Vizag Center of LBPI, and she'll be taking us through how to manage smaller perforations and applications of TA, tissue adhesives. Over to you, Shilpa.
A very good morning to the dignitaries on the dais and a good morning to everyone. First of all, I would like to thank Dr. Somashila for the opportunity and also Dr. Kavya for helping with the videos. So we'll look at how to manage small perforations using tissue adhesives. So when we perform therapeutic penetrating keratoplasty in a perforated corneal ulcer, which is usually of larger size, the graft tends to fail early and an endothelial keratoplasty or an optical penetrating keratoplasty becomes mandatory later on. But when you have a smaller perforation, you can get away by doing a glue BCL, and later on you can perform an optical penetrating keratoplasty, which will eventually have a better outcome compared to a therapeutic penetrating keratoplasty. So what tissue adhesives are available? We have synthetic polymer-based adhesives available. We have the naturally derived polymer-based adhesives, which are fibrin-based tissue adhesives. So the synthetic polymer-based adhesives are the cyanoacrylate, polyethylene glycol-based, and dendrimer-based adhesives. But the commonly used ones are the cyanoacrylate-based tissue adhesives. So look at what are the advantages of the cyanoacrylate tissue adhesives. So it is more effective when we use the tissue cyanoacrylate in perforations lesser than 2 mm, but it is also useful in perforations up to 3 mm size. And it mainly provides tectonic stability, avoiding the need for keratoplasty later on. It inhibits collagenolysis, proteolysis, and stromal melting. Also, it is shown that tissue cyanoacrylate exhibits bacteriostatic effect on gram-positive bacteria. So cyanoacrylate may not be an ideal tissue adhesive. We do have some disadvantages. It is not useful when the perforation is too large, and it exhibits some cytotoxicity. So when it enters care should be taken that it should not enter the anterior chamber. Cyanoacrylate glue invites deep corneal vascularization, which leads to poor survival, graft survival outcomes later on. Cyanoacrylate rapidly polymerizes when comes in contact with any body fluid. So an irregular rough surface is created, which makes applying a glue BCL later on mandatory. So when to apply tissue adhesive? So when you have a perforation, as said, to less than 2 mm more effective, and up to 3 mm you can manage. When you have a decimetocele or an impending perforation, when you have a persistent epithelial defect with stromal thinning, when you have active collagenolysis. So the first two, the perforation and the decimetocele, should be performed in an operating room, while the last two, the stromal thinning cases and the active collagenolysis, you can perform them in your own OPD setup. So what all do you need to perform a glue BCL? So first of all, the commercially available ones, you will get the tissue adhesive solution in a vial. A 1 ml syringe will come along with it. A needle will be there. So we have to load the solution into the syringe, and either using a Vexel sponge or a 26 gauge needle, you can apply the tissue adhesive on the area of thinning or the perforation. And later on, after the polymerization happens, you can apply the BCL. So let us look at how the actual technique is performed. Epithelial debridement is mandatory because the tissue adhesive does not stick to intact epithelium. So using a surgical sponge, you can just raise the loose epithelium around the area of infiltrate. You can also use a non-tooth straight forceps to peel off the epithelium. Or use a 15 size blade to scrape off the epithelium. Especially in post-PK PEDs or in ocular surface cases, do not peel off too much of epithelium to avoid poor healing, epithelial healing later on. Apply the glue as a thin film over the area of thinning. Do not apply excessive TA. After the polymerization is complete, apply the BCL. So this is how you can, these are all the techniques how to apply the tissue adhesive. A surgical sponge can be used. A 26 gauge needle can be used. It is advisable to not touch the tissue adhesive immediately after application to avoid peaking of the tissue adhesive. You can also use iris repositor. Also, it is advisable to not apply too much of tissue adhesive to avoid mount formation especially in decimetocele and in large perforations. The bandage contact lens will not sit properly on the tissue adhesive and will lead to poor patient tolerability and later on papillary hyperplasia in the upper tarsal conjunctiva. So one important thing is to dab the backside of the Vexel sponge on a dry surface twice or thrice to avoid excessive application onto the surface, corneal surface. So next step is forming the anterior chamber. So while making the side port, it is advisable not to hold the limbus at the opposite side of the side port. This will lead to collapse of the hypotenuse globe and reopening of the perforation. So instead, it is better to hold at the same site where we are planning to make the side port and direct the MVR knife vertically into the anterior chamber. So finally, let us look at how a perfect glue BCL and AC reformation is done. This is a 41-year-old female with fungal keratitis. The patient was taken to the operating room. The epithelium was debrided around the area of perforation. The area of perforation was noted. The tissue adhesive was applied. Immediately, the sponge is retracted back, and this should be avoided. Touching the glue immediately without drying is avoided to avoid peaking of the tissue adhesive. A 26 gauge needle was used. The areas of peaking were trimmed off using Vanna scissors. Using a 29 gauge needle, anterior chamber was formed and later on replaced with saline. And checked for any leak. The BCL is finally placed. And this is the post-operative outcome with the full formed anterior chamber. Yeah, thank you. Thanks for the opportunity.
Thank you so much, Dr. Tarini.